possibly one of the greatest complexity existing. Anatomy is one such a subject which unlocks this mystery. I take a great pleasure in welcoming our speaker here to the expert in unlocking the mystery, Dr. Sundara Pandian, Professor and HOD at SRM Medical College. He has a vast teaching experience for over 30 years. He has also been examiner for several medical and dental examiners throughout the India. He has over 53 publications and his interests include microanatomy, embryology, genetics and biotechnology. He has received several awards which include Quality Research Award, Best Teacher Award awarded by Research Foundation of India, Global Faculty Award awarded by AKS Education, Mahatma Gandhi Leadership Award presented by NRI Welfare Society of India, Lifetime Education Achievement Award in the year 2015 awarded by International Institute of Education and Management, New Delhi, Bharat Vidya Gaurav Prasakar Award in the year 2016 awarded by Global Achievers Foundation Individual Contribution for National Economic and Social Development, Best Performance Award awarded by SRM University. He also won Dr. M.M. Cooper Best Paper Award for his paper on congenital diaphragmatic hernia and also dilated coronary sinus with persistent left superior vena cava. I take a great pride in welcoming you, sir. Welcome, sir.
Thank you, ma'am. Thank you for the nice introduction. Respected senior anatomy professors, friends, my dear students, very good morning to one and all gathered here. So today the topic is evidence-based anatomy. So as part of that theme, evidence-based anatomy, so the title is Unveiling the Secrets of Human Anatomy, Evidence-Based Teaching and Learning Strategies. So what is that evidence-based teaching learning technology? So here it is given as learning and teaching. First learning, then teaching. So that's what insisted now. We have to learn first, then only we can teach. So that's why it is given as evidence-based learning and teaching technology. Actually, it is an approach or it is an pedagogy, but scientifically proved to better outcome. So actually, it is more effective and more efficient for both teachers as well as the educators. So actually, by incorporating that evidence-based learning teaching principles, the medical educators can enhance their teaching practices. So that is more important as per by our NMC norms, resulting in better prepared healthcare professionals and improved patient outcome. So that is our evidence-based teaching learning technology. So what are all the importance of it? As I told already, it is scientifically proved. So many evidences are there for each technology. So I am going to refer each and every one in each slide. Actually, it helps the educators to decide the pedagogy method for better outcome. Actually, by incorporating evidence-based strategies, instructors can create dynamic and engaging learning environment. So that is important now. Our traditional learning is teacher-centric, learners are passive learners. So now what NMC is insisting, the students should be active learners, so we have to engage them. So meta-analysis by Freeman et al. In 2014 proved that active learning methods improved examination score, reduced failure rates. That is important. In STM means science, technology, engineering, mathematics, including anatomy. So improved outcome comes. So next, another evidence in 2019, Lindenholm demonstrated that incorporating technology in anatomy education improved students' spatial understanding. Improved spatial understanding as well as retention of anatomy structures. So that is also more important for the clinical practice. So now we will have one activity. Please all of you take your mobile, go to Google, type join.nearport.com. Join.nearport.com. Hope we have enough time, so all of you can try. Go to Google, type join.nearport.com. Nearport.com. So that's what we have to engage the learners. So that is my idea. Okay. So next slide I will project the code. So this is the instruction. In this place you have to enter the code. Next you have to type your name. You have to enter your response. Finally submit. So this is the code. Enter this code. R6IQ8. All are caps. Are you ready? Please you switch on your data. Your mobile data, please switch on. கொஞ்சம் ஹெல்ப் பண்ணுங்கம்மா ப்ளீஸ். Shall I move? So you'll be getting the question. How often you use digital technology in your classes? Are you getting the question? Yes. Yes, very good. 46 participants are there. It's nice. Pardon? Oh, okay. So that limitation, free, no, it is free, that's why. So it's fine, 60 are there. So regularly you are using, more often, no answer, very often, every day. Okay, it's fine. So that shows that you are all engaged, isn't it? That's what we have to engage the students now. So instead of that passive learning, we have to promote. Okay, shall we move? Thank you for the active participation. So they are all nothing but pedagogy methods. So first one is active learning. So what is that active learning? Already I told. So we have to engage the students. So that is active learning. They have to participate in the learning. Okay. So that is active learning. Next is technology integration. So we have to integrate technology. So nowadays it is also insisted by National Education Policy 2020. So next, use of visual aids. Use of visual aids to enhance the learning. Next, formative assessment. Next, application of real life scenario. So that is problem based learning. So next is collaborative learning. So collaborative learning of the learners. Next, addressing the learning style. So that is more important. So we have to concentrate on learning style of the students. Based on that, we have to change our pedagogy methods. So next one is building a supportive environment. So later on we will tell what is it. Building supporting environment. Finally, continuous improvement. So these are all the evidence-based methods scientifically proved to engage that active learning. So we will see one by one with some of the digital tools we can use for each. So first one is the active learning. So role of active learning. So it is important to note that the active learning promotes students' engagement. Next, critical thinking. Next is knowledge retention. So that is important. So our students used to read anatomy only in first year. After that they used to forget everything. Then they go to the next year. Then final year they will totally forget anatomy. But that knowledge retention is important. So for that our active learning helps. Next, techniques like group discussion, problem based learning, hands-on activities are effective for human anatomy. So research already proved that active learning leads to better understanding and long-term retention of anatomical concepts. So here also evidence for this. Michael et al. In 2019 proved that the traditional teacher-centric learning students, if you compare those students with active learners, the active learners outperformed. So that is the proof. It is proved by Michael et al. So like that, Prakash et al. In 2020 proved that it helps for long-term retention of anatomical concepts. So now we will see what some of the digital tools that can be used for active engagement of these students. So first one is Nearport. It is an active, interactive educational platform. Okay, so that is Nearport, that only we have used now. So that is Nearport. These are all free for certain limits. So we can use for our regular classes. So next one is, you may be familiar with this, Kahoot. So this is also one interactive digital tool we can use in our regular classes. So this is called as gamification. So actually we have published a paper. This type of gamification improve the students' performance. So now new one, it is Plickers. So for the previous two, the students, they have to bring the mobile. For these Plickers, they no need to bring the mobile. So we have to scan the answer through our mobile. So they no need to bring, just they have to write the name, they have to answer for these questions like this. So we can scan, if the students show the paper, we can scan it. So that is the new one. Students no need to bring the mobile. So that is Plickers. So these are only some of the tools, digital tools that can be used for active learning. So at the end of the session, I will give one list of digital tools that you can try. So next, shall we have one more activity? Take your mobile, go to Google, type menti.com, menti.com. So limitation may be there, quickly try menti.com. Have you got it? Got it. So next, I will tell the code 2858778. Sorry, 2858778. So that is the code. If you put that code, you can answer for the question. You can see your response in this screen. 2858778. So it is there in the screen. Students participate actively. So you can see your response here. Fun learning, isn't it? That's what we have to motivate the students nowadays. Mobile means they will be very happy. Yes, 41 responses, very good. So what do you feel? Very good, 52 Okay, shall we move? Very good, that's what we have to engage these students. So have you already experienced Menti? Mentimeter or menti.com? Okay. So we can use for our regular classes like this in between the class to motivate that students, we can use this. Hope that Klimbatics is sleeping, all are awake. So next we go to the next one, technology integration. Am I audible? So technology integration. So integrating technology in classrooms, we can enhance the anatomy education. So actually nowadays most popular one is virtual dissection tools. We have virtual dissection table also now, as we have dearth of cadavers nowadays. Slowly we are also moving towards that. Anyhow, all those digital tools are not going to replace our cadaveric dissection. So like that 3D models, next interactive apps like this. All are the digital tools incorporated in the medical education now. All these technology improves spatial understanding and anatomical visualization. Okay, so this is also proved by D. Santis and Hickey in 2017. So the technology integration enhances the spatial reasoning skills and anatomical knowledge. Next one is in 2018, Nadim demonstrated that 3D models enhance the students' complex anatomical structure understanding. So we are also trying, one of my staff is doing PhD in that 3D model. So that enhances the understanding. passing through the lumen reaches the villi. So it is the virtual lab, actually Labster virtual. Certain limit it is free, we can use. What I am using now is free only. So this is one common digital technology. Next is primal picture. So in the we have 3D models. So 3D models. See that in this we are able to make out that tongue rotating. We are able to make out that extrinsic muscles of tongue. Clearly we can make out that. So before dissection we can give this preview. Then we can ask the student to go for the dissection. So 3D model with muscles of facial expression, tongue with extrinsic muscles, nicely hyoglosses, genioglosses and all we are able to make out. So that is the 3D model. So the company is Primal Picture. Okay. So this and all free only, we can use it. So next, use of visual aids to enhance the learning. So visual aids like anatomical charts already we are using, diagrams we are using. Now the popular one is our PowerPoint presentation with multimedia presentation. So we can enhance the PowerPoint with audio, video and interaction. So that is called as multimedia presentation. So that is nothing but PowerPoint only. So commonly used one is our PowerPoint. Regularly we are using it. So this is also proved, the systematic review by Alexander et al. In 2019 proved that this usual of visual aids improve the students' performance as well as understanding of anatomy. So another Paivanti et al. In 2018, they also proved that it increases the students' recall and identification of the structures important for our spotters. So next we will see how that PowerPoint can be used for interaction, of course for incorporation of video and audio. That of course you may be familiar with that. So if we in the PowerPoint regularly we are using audio and video. So this is how the PowerPoint can be used interactively. So this is the question. So we can ask the question. So if they don't answer, we can give the answer also. So it is Rathke's pouch. So that's what we can use for interaction. Okay. So next we have one video. So that video is incorporated in that PowerPoint. So that is also very nice one. So please go through it. So loop of small intestine with nice plica circular. You are able to make out with epithelial cells and villi.
These cells are perfect for absorption because they have fingers, which increases the surface area for absorption of nutrients and other molecules through the membranes.
The plica circular is very nice.
Alcohol moves across the epithelial cells
How the digested particles are reaching the circulation.
into the capillaries. The capillaries are made of endothelial cells.
How they are passing through the
The biological
endothelial lining.
allows small, uncharged molecules like ethanol, CO2, and water to pass directly through the membrane by the process of diffusion. Like all internal organs, the stomach and small intestine are wrapped in a fine network of capillaries. Once alcohol crosses the intestinal space, it is carried by the bloodstream into the veins, where it can then be distributed through the cells of different organs like
How finally they reach the organs.
kidney, lungs, skin, and even in the unborn baby.
Next we can incorporate audio. So that is podcast. The volume is, are you able to make out? Just we can put our audio itself we can incorporate. That's what we are addressing, the various learning styles. So we can incorporate audio in that PPT. So next is a formative assessment. So nowadays NMC is insisting the formative assessment. So more marks are allotted. Now as per the recent regulation, 500 marks for theory, 500 marks for practical. If I am correct, 500 plus 500. So this formative assessment. So this is our regular internal assessment. In addition to that, daily during our regular lecture, we have to conduct assessment. So this assessment is called as assessment for learning. Assessment for learning is called as formative assessment. We are not assessing the knowledge of the student. We are giving this assessment to the students for learning purpose. That only called as formative assessment, assessment for learning. Okay, for this we can use different medical applications. So here also we have some of the digital tools, quiz, poll and the concept mapping we can use. This and all free to certain extent. So this is also proved. So this formative assessment enhances the learning and the knowledge retention. So these two references are there. So they are helping for anatomy examination performance as well as better retention of anatomical knowledge. So this is that app, so called as quiz. So this we can use during our lecture itself. We can give in between or at the end, we can give 5 questions related to our topic. Okay, so we can ask the students there itself. They have to, now you are going to do. Is it boring? Okay, we can do that. We can have that practice of quiz. So take your mobile, go to Google, joinmyquiz.com. Joinmyquiz.com. The questions will be funny for the anatomy faculties. You don't bother about that. Purposely you make mistake also. We can see the leaderboard, how it comes. Okay. So this is not the test. So this is assessment for learning. So have you opened? So I will tell the code, your typer name. So that is the code 888126. 888126. We can see the leaderboard once you answer for this. Yes, very good. Most of you joining. CTC, what do you feel? Easily we can use, isn't it? During our regular lecture itself, for formative assessment we can use. So the responses will be recorded. We can download the Excel. We no need to sit and make entry of the marks. Shall I start? Shall we have the music or mute it? Shall I mute it? No need. Make mistake also. So that's what proving anatomy is not old, it is new. That's what madam told in the morning. It is new. We have many new methods to learn anatomy. Aishwarya got 10. So that's what the student can directly see that responses. Sit over. Anyway, we have time. Lunch will be ready by 1 o'clock, you know. Already ready. Only few more minutes. Only one more activity we have. So that is for collaborative learning. So leaderboard, Aishwarya is top. Sivan Asen. Yes, like that you can see the leaderboard. It will be interesting. So the student will get motivated ultimately. So I will end it. Still people are answering? Still it is going on. What sir? Are you doing? Limitation. Oh, sorry. So I will end it. Yes, final leaderboard, first, second and third. So that's what we can motivate our students. We can download that Excel. Same thing we can keep it for our internal assessment calculation. So next, application of real life scenario. Of course, we are all familiar with that. Nowadays, NMC is insisting for that. Problem based essay question, short notes as well as MCQ. This also increases the retention of anatomical knowledge. So here itself we are telling about the clinical history, what way it will be useful for them. So that's what nowadays yearly clinical exposure is also there. So in first year itself, students are seeing the cases. They are correlating the anatomy knowledge for the clinical purpose, real life scenario. It is also proved by these two studies. So next is collaborative learning. So we are encouraging the collaborative learning now with small group discussion. So they can learn themselves. Nowadays that STL is also there. So it promotes the teamwork and the communication skills. So for that purpose we are using that collaborative learning. So for that also so many digital tools are there. So we can use only, I will use only one digital tool for that. So see this interesting one. This is the app called as Myro. Whole class can participate in this collaboration. They can be divided into 4 groups. In each group they can participate. They can give their opinion. They can interact with the other students. So they can collaborate and come to a final conclusion. That is Myro. So this is also free for to certain limit. So next one is X-Mind. Actually initially it was introduced for mind mapping. Nowadays it is used for our collaborative work also. So that is X-Mind. That is also free tool. So next one is Padlet. So you can scan this QR code from your place itself. You can scan it. From there you can scan. This is called as Padlet. So in one wall will be there. In that wall individual opinion will be coming as a separate note. So we can collaborate with others. Once you scan, sit over. Madam, if you watch them, that's what she said. Once you scan, one plus will be there. You press that plus. You can answer for the question and you can publish it. At the site of subject, you put your name. Your name will come. Press the plus. You will be getting one space. You will be getting that subject. In that subject, you have to put your name. It is there in the next slide. Once you open Padlet, click that plus icon. In the place of subject, type your name. Next you have to type your response. Click publish. Yes, that's what one wall will be there. In that we can record our own ideas. We can collaborate with others. What, ma'am? Anything. Anything we can try. Oculomotor nucleus. Thank you, ma'am. Finally, you participated. So it is not only for youngsters, seniors also enjoying this. It is collaborative tool. So all the lymphatics of your brain is sleeping. So that's why people are active, isn't it? That's what Madam told. Today only I learned that lymphatics are sleeping, we are awake. Okay, I will stop with this. Okay, so that is Padlet. Okay. So next important one, addressing the learning style. So already we are familiar with that WARK model, VARK, WARK visual, A for auditory, the R for write or read. Next is kinesthetic. So these are the 4 models of learning. So WARK model, visual. So visual aids we are giving through PPT. So next audio. So we can insert podcast or talking itself audio only, audio learners. Next R for reading and writing. Next K for kinesthetics, so that is for practical work. So already I told about all these things in visual aids itself. PPT can be used for audio learners, visual learners, for kinesthetic learners also. So this is also proved. So we have to mix the methods, so that is important. So some of the students may be visual learners, some of the learners will be auditory learners, some of them can learn only through practice. So that is kinesthetic learners. So we have to analyze the student. So or otherwise we have to mix all these methods. So that is multimodal learning approaches, including auditory, visual and kinesthetic, improved the learning outcome. So that is proved in 2018 by Prince as well as Fleming et al. In 2018, that improve the academic performance. So just I will put only one. So that is first one is for auditory learners, podcast. So for visual learners, 3D model. For kinesthetic learners, the practical work. So all these 3 type of learners are engaged here. So that is addressing the your learning style. So next is building supportive learning environment. So that is important. So in olden days we will be like a terror. So students will be silently sitting and listening. So that should be removed. So okay, it should be interactive. So we have to encourage open communication. We have to provide constructive feedback. So that is important, constructive feedback. We have to address the students' concern also. Then only students will be friendly with us. So it will enhance the learning. So that's called as building a supportive learning environment. So open communication, constructive feedback and addressing the students' concern. So that helps for your student engagement as well as participation in anatomy. All are proved one. So this is in 2019 by Mercer and Ryan. Then 2021 Gang et al. Proved this, the building the supportive learning environment. So for that commonly used one is Survey Monkey. It is also free. So for constructive feedback, immediate feedback, we can use this Survey Monkey. It is also free. Survey Monkey, anyhow we are not going to use it now. So next is continuous improvement. So what is this continuous improvement? So not the performance of the student. This continuous improvement is nothing but we have to change our teaching method. We have to change our teaching strategy based on the feedback of the students. So continuously we have to change our teaching style. So that is called as continuous improvement. That is also proved. Based on that feedback, based on that assessment, we have to change our teaching style. So that is called as continuous improvement. So that is also proved. Evidence-based techniques requires continuous improvement for optimal result. For optimal result, this is very, very important. Feldman et al. In 2022, it is proved. Like that, Srinivasan et al. In 2019 also proved that continuous improvement enhances the learning outcome. So now another one is 21st century skills. So it is also insisted by NEP 2020. So our NMC also. So what are those 21st century skills? Collaboration. So we have seen already. Next, critical thinking. Next, creativity. Finally, communication. So these are the 21st century skills. So if we use all these digital technologies, if we change our teaching styles, we can produce these skills on our medical students. So conclusion, so this evidence-based teaching learning in human anatomy are crucial for the better learning outcome. So your active learning, technology integration, visual aids and real life scenario are effective strategies supported by research. By combining these methods and fostering the supportive environment, educator can facilitate a deeper understanding of human anatomy and prepare students for successful career in healthcare and medical science. So this is for feedback only. You can scan from there itself. You can scan this QR code. We can give you your feedback, positive as well as negative. So negative feedbacks are most welcome. I'll. Thank you so much for your patient listening. So active participation, that is more important. Thank you very much. So I hope I have done my job. Thank you all.
Thank you, sir. Your way of activity teaching and the activities you have given us put us on our toes. We really enjoyed your oration for. Thank you, sir.
Now I request the office bearers of Association of Anatomists of Tamil Nadu, President Dr. Vijisha, General Secretary Dr. Senthil Kumar and Treasurer Dr. Prakash sir to felicitate Dr. Sundarapandian. for original research. We have two categories of award session here. The first one is Dr. M.M. Cooper Award session for faculty category. The second one is Dr. Leela Krishnamurthy Award session for UG category. We have three judges among us for this session: Dr. Melanie Rajendran, Senior Anatomist, Dr. Sudha Rao, Senior Anatomist, and Dr. Vijisha Palgunan, currently the President of Association of Anatomists-Tamilnadu. I hope we have already seen enough regarding them. Welcome, Madam. Before the session, let me read out the regulations of this session. I hope you might have already seen them on the website. Still, it's my duty to read them. The papers should be on original research. Time for presentation for each paper is 7 minutes. The first bell will be given by 5th minute and the final bell by 7th minute. Papers will be assessed based on originality in research, way of presentation and time management. Let's start the session. We are starting the session from faculty category for Dr. M.M. Cooper Award. Our first presenter is Dr. Suganitha Balasundaram, Faculty, Savitha University, Aakash Institute of Medical Sciences, on the title, A Preparation of Pungamia pinnata leaf extract inhibits the apoptosis of cortical neurons in pre or post-stroke rat via regulating the expression of Bax BCL2 and caspase-3.
Good afternoon, one and all present here. Myself, Dr. Suganitha Balasundaram, Senior Resident from Aakash Institute of Medical Sciences, Bangalore, come PhD scholar from Savitha University. Now I am going to present part of my research work, that is a preparation of hydroalcoholic effect of Pungamia pinnata leaves inhibits the apoptosis of cortical neurons in pre and post-stroke rat via regulating the expression of Bax BCL and caspase-3. So my area of research interest is neuroanatomy, especially on stroke. So why stroke? So cerebral ischemic stroke is the most commonest cause of disability worldwide. So the concept of neuroprotection and neurorestoration is gaining a lot of attention in the hunt for innovative therapies that could protect the brain tissues as well. It enhances the functions by improving the cognition and motor function. So the aim of this study is to compare and determine.
We have three judges among us for this session: Dr. Melanie Rajendran, Senior Anatomist, and Dr. Vijisha Palgunan, currently the President of Association of Anatomists-Tamilnadu.
Good afternoon, one and all present here. Myself Suganitha Balasundaram, Senior Resident from Aakash Institute of Medical Sciences, Bangalore, come PhD scholar from Savitha University. My area of interest is neuroanatomy. So I am going to present part of my research work, that is a preparation of hydroalcoholic extract of Pungamia pinnata leaves inhibits the apoptosis of cortical neurons in pre and post-stroke rat via regulating the expression of Bax BCL2 and caspase-3. So why stroke? Cerebral ischemic stroke is the most commonest cause of disability worldwide. So the concept of neuroprotection and neurorestoration is gaining a lot of attention in the hunt for innovative therapies that could protect and prevent and enhance the brain tissues by improving the cognitive and motor abilities. So aim of this study is to compare and determine the effect of 70% ethanolic extent of Pongamia pinnata leaves on stroke-induced model of Vista rats. This is a pictorial representation of my study. So the reason for the journey started from stroke into Pongamia pinnata leaf is quite interesting. When I used to see the case in my clinic, I always used to think that I have to do something for stroke patient, particularly to manage their pain and disability. Why? Because it will create an impact on their physical and mental status drastically. In that way, I started move towards the stroke cases. Then when I used to interact with them to take a history about it, I came to know that most of the patients are visiting to the traditional practitioners to get some herbal powder or the kashaya to enhance the improvement of stroke. So then it developed a curiosity in my mind that I want to know what kind of herb it is. Then I started gathering the information related to that particular herb by some authorized sources, and I came to know that that is Pongamia pinnata leaf. So it is not only in the India, even in other countries also is given in a form of herbal therapy, but the bad thing is it is not proven scientifically for the brain tissues, particularly for stroke tissue. But then I started gathering the references and documented related to this Pongamia pinnata leaf, and I came to know that it is proven for many conditions in a form of therapeutic agent. Particularly, it works against lipid, it is working as anti-lipidemic activity, then for the diabetes, for diarrhea, even for fever, and in the case of anticonvulsant activity, as well in the Alzheimer's activity also, but they are using all the parts of this tree particularly. So coming to the Pongamia pinnata leaf, it is called as Pungai Ilai in Tamil. So this Pongamia pinnata is an evergreen tree which is vastly distributed in India. The plant is consisting of various phytoconstituents belonging to alkaloid, glycoside, flavonoid, tannin, fixed oil and carbohydrates, etc. So there are many herbal remedies individually or in combination have been recommended in various medicinal treatises for the cure of different diseases. That's what I mentioned in the beginning only. It is used for many conditions in a form of therapeutic agent. This is a picture to represent the tree of Pongamia pinnata and the leaf. Coming to the method, in male Vista rat, ischemia or reperfusion is incorporated in the brain of rat by occlusion of bilateral common carotid artery method by 60 minutes of occlusion followed by 72 hours of reperfusion in neuroprotective group and 21 days of reperfusion in neurorestorative group. So the examination of neuroprotective and neurorestorative effect of Pongamia pinnata leaf extracts on the brain sample is done by the molecular analysis of Bax BCL2 proteins. So this present study to determine the effect of pre-post treatment with 400 milligrams of Pongamia pinnata leaf extract on functional motor recovery. This is an image to represent the BCCAO model. Coming to the grouping of animal, the 42 rats were divided into 6 groups, 7 in each. The group 1, positive control, that is normal. Group 2, sham control. There the skin incision was done and separated the common carotid artery but not ligated. Then group 3, that is negative control for the neuroprotective group. In this a new stroke is induced. Then group 4, experimental group, this is stroke induced followed by the treated with 400 mg of Pongamia pinnata leaf extract. So group 5 is negative control for stroke induced group and group 6 is experimental group or treated group for neurorestorative group. The neurological examination is done with the help of Bidesen et al. Method. Here you can see the stroke-induced rat is having cyclic behavior, and here it is a tail suspension test which is also showing it is not using both the forelimbs symmetrically, which means the right side is paralyzed here. Even in the previous one cyclic behavior, the rat used to rotate on the paralyzed side. This indicates that it is the stroke-induced model. So it is performed after 24 hours of reperfusion, and animals were sacrificed and their brain samples were used for molecular studies. So the molecular study is carried by RT-PCR. So RT-PCR characterization involves two steps. One is RT reaction and PCR amplification. So this is done with the help of CFX96 touch real-time PCR detecting system. So the synthesis of primers are done, that is forward and reverse primer, followed by it is carried for the standard golden method of Trizol method to extract the RNA from the brain tissues with the enrichment of dissolved DEPC treated ionized water. It helps to extract the RNA from the target gene. By the ANOVA test, the multiple variant test is used for statistical analysis. So the probability criteria value is less than 0.005, which is considered significant here. So this is a graphical representation of the study for neuroprotective and neurorestorative group. In this, the BAX level is very high in stroke-induced group compared to the treated group. The treated group is almost equal to the normal group of the animal. So coming to the discussion, Blanco et al. Stated that BAX is a pro-apoptotic protein. It plays a vital role in the regulation of cell death of various cell types, including the neurons. So the expression of BAX protein will be high in case of neurological cell death or damage. Even the Shrivakar A et al. Also mentioned as this ischemic experimental study, even after traumatic brain injury sequence, the BAX remains unchanged if there is no cell death. If it is there, if the neuronal cell death is there, definitely the BAX is also increased. Zhao H et al. Mentioned very clearly the increase of BAX expression is directly proportional to increase of neuronal cell death. Even the same, the Maningwa and Saini et al. Stated very clearly about the therapeutic usage of all the parts of the Pongamia pinnata tree. So in this present study, we found that the BAX protein level is high in stroke-induced group as well. It was found more in the lesion site compared to the treated group. So coming to the conclusion, the ethanolic extract of Pongamia pinnata can treat cerebral ischemia or stroke brain. The expression of BAX shows that Pongamia pinnata leaf has very good neuroprotective and neurorestorative activity on the rat brain tissues. These are my reference. So this automatically induced interest for me to carry this study into the clinical trial. Definitely I will do it in the future. Thank you so much for this opportunity. Thank you, ma'am. Of HNE and Cresel violet, that is mainly for, no ma'am, in this I did not include, ma'am. Yes, ma'am. Ma'am, pictures I have, ma'am. I have in my pen drive. I can show, ma'am.
You mentioned about BAX protein level. Was there any other parameter which you considered?
Yes, ma'am. Along with the BAX, I have done with TNF alpha and this thing HIF alpha also, HIF1 and BDNF, GDNF.
Out of all these BAX has got any?
This is only apoptotic marker, ma'am. Other two are neurotrophic markers, BDNF and GDNF neurotrophic marker, and HIF1 for anti-inflammatory activity. So I have seen in all three categories.
Good afternoon. What are your histological findings about these patients? You told you have analyzed?
Yes.
Histology matches with your
Yes, sir.
expression?
Yes, sir. In Crescel violet also, we have seen in the stroke-induced group, we had actually more of, dead cells, dead neurons. It was representing as pycnotic nuclei. The cells space was more in between the nuclei and the cell wall. Those changes we have observed, sir. Yes, sir. Yes, ma'am. Only this acridine orange under confocal microscope, ma'am. All other parameter usual light microscope, ma'am. Sure, ma'am. Sure, ma'am.
Go for the second presentation. Let me announce the timings for the presentation. The presentation is for 10 minutes. 8 minutes, the first bell will be given, and the final bell at the 10th minute. 5 minutes for discussion.
Yes, my topic of presentation is pattern of first costal cartilage calcification for sex determination in North Indian population. The first rib has the primary center for ossification that appears around second month of intrauterine life. The secondary centers for the head and tubercle, they appear around puberty, and fusion is completed by 20 years of age. The first chondrosternal joint is an unusual variety of synarthrosis, inaccurately called as synchondrosis. The attachment of the first rib to sternum also becomes a synostosis with age. Naked eye appearance of first costal cartilage calcification and its appearance radiographically seems to be a less addressed area, and since there is dearth of literature about the radiographic appearance and the pattern of first costal cartilage calcification, the present study has been conducted. So the aim of the present study is estimation of sex by pattern of calcification of first costal cartilage in North Indian population. The present study was done in the Department of Anatomy in collaboration with Department of Forensic Medicine and Department of Radiology, Pandit B.D. Sharma, PGIMS, Rohtak. Now the specimen comprised of 50 pairs of first rib along with manubrium in both the sexes in the age ranging from 15 to 30 years. The specimens were collected from the cases done for medico-legal autopsies in the Department of Forensic Medicine after taking the proper consent from the legal hire of the deceased. Specimens whose autopsies had been performed within 24 hours of death were analyzed radiographically to see the pattern of first costal cartilage calcification. The following cases were excluded from the study: accident or trauma cases, or where the first rib or manubrium was showing any signs of fracture or malunion. The specimens were retrieved from the cadaver and were tagged and numbered. The specimens were left in the glass container filled with saturated solution of sodium chloride for 6 to 8 weeks to macerate the soft tissue. The specimens were then observed grossly for the pattern of calcification and then were radiographed in the Department of Radiology and were categorized in different categories as per the patterns described by Rao and Pai. So the first calcification is no calcification, as we can see here, the transparent cartilage being visible. Type A is marginal bracket type of calcification. Type A1 is marginal linear type of calcification. Type B is central or bifid type of calcification. And type C is basically complete or mixed type of calcification, that is the combination of type A, type A1 and type B. So after tabulating the frequency distribution of costal cartilage calcification patterns, the predicted value was calculated by the following formula, where where predictive value is equal to P1 upon P1 plus P2. P1 indicates the prevalence of the pattern in the sex predicted by the pattern, and P2 is the prevalence of the same pattern in the opposite sex. So results and observation, this is the tabulated form of different types of calcification. Now no calcification was found in around 5 cases in male. Type A calcification was found in 10 cases in female and 5 cases in male. Type A1 was found in 14 cases in female and 13 in male. Type B was found in 1 case in female and type C was found in 2 cases in males. So after applying the formula, which is predictive value is equal to P1 upon P2, P1 upon P1 plus P2, the result was that type A, type A1 and type B were found more frequently in females on both sides with the estimated predictive value of 66%, 50% and 100% respectively. And type C calcification was found only in the males, in my cases, where the predictive value was found to be 100%. Discussion. So now different authors, now only these authors, Sanders, CF, Rao and Pai, Navani, Zanger et al. Have done these studies. I mean, I got the papers only from these studies. So there is limited amount of literature available for this. And according to them, they found out 3 different types of pattern mostly, marginal, central type and female type, almost all these studies. If I do the comparison of different studies from my study, marginal bracket type of calcification was mainly found in males in Rao and Pai study in around 90 with predictive value of 92.3%, and central type was found in females with predictive value of 96.5%, and mixed type was also found in females 68.9%, which is almost similar to what I have done in my study. Sanders marginal bracket calcification was found only in males, central type was found only in females, and mixed type was found only in females. And in Navani et al. Calcification, marginal bracket was found in 95% of predictive value in males and 93% predictive value in females and 57% in females. So conclusion, marginal bracket type and central type patterns of calcification occurred more frequently in females in my study as well as found in other studies, with the predictive value of around 66.32% and 100% respectively. Mixed type of calcification occurred more frequently in males with the estimated predictive value of 100%, which concludes that calcification of first costal cartilage exhibits a definite pattern in relation to the sex involved. These are the references. Thank you. Ma'am, first strip, actually it was very easy to retrieve because I mainly got my cases from the autopsies. So first strip along with manubrum was easy to retrieve and could be easily studied. That's why I focused mainly on the first strip.
Significant you found in this study?
Ma'am, first of all, that not only the long bones, rib along with the first costal cartilage can also be used for sex determination as well as for age determination. Sex determination as well as for age determination.
Can you suggest any reason why the marginal classification and central classifications are prominent, I mean, more in female?
Yes, sir. Actually, the thing is, this study has been done mainly in the from the autopsy cases. My next thing is to do it on the live cases so that I can correlate why these calcifications are found. These patterns are found mainly in the females or male. I could not correlate it with the reason, but for the future, I am planning to do it in the living so that maybe I can find out a reason why marginal and central type is found mainly in that. Yes, sir. Yes, sir. I'll be continuing this in the living now. Yes. Yes. Thank you, sir. Sorry, sir. But, sir, easy availability and moreover, sir, if the first costal cartilage about the other ribs, none of the literature was available. The first rib, little bit of literature was there so that I could get a baseline. Very few, sir. 1 or 2 articles only. I mean, for this, I could found a little bit more than for the other, as compared to the other ribs. So that is why, sir. I mean, I needed some baseline to start my study, so that is why. Yes. 30 pairs, sir. 30 pairs. 30, sir. Yes, sir.
It seems to be little.
Yes, sir. It is.
take the
Yes, sir.
pan population, you want to say
Sir.
male and female,
Yes, sir.
right? Universal. Then 30
Yes,
is
sir.
very less.
It is less, sir. Definitely, sir. Yes, sir. That is why I'm continuing. I'll be continuing this study ahead also.
And you said that in last slide that certain type of calcification is 100% predictive.
Predictive, yes, sir. Almost, because almost all cases in males, this type of pattern was only found. Like, yes.
With the sample of 30, 100.
Sir, 100.
Very, very
Yes, definitely, sir. Yes, sir.
you need to have a,
Sure, sir.
I will not say huge, but
I need to number, definitely, sir. Okay, sir. Thank you, sir.
Our next presenter is Dr. Pratapati Gajendran, faculty, Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapith, Puducherry, India. On title, Corroborative Evidence of Gross Anatomy and Sono Anatomy of Supraclavicular Brachial Plexus, a Cadaveric Study.
Very good afternoon to all eminent faculty and respected teachers. I am Dr. Pratapati, Professor from Department of Anatomy, Mahatma Gandhi Medical College, Puducherry. I stand here to present my research paper, Corroborative Evidence of Gross Anatomy and Sononatomy of Supraclavicular Brachial Plexus, a Cadaveric Study. So as we all know, brachial plexus is formed from the ventral roots of the C5 to D1 and it is most compactly arranged at the level of upper and middle and lower trunks. So nerve blockade at this level has a great possibility to block all the branches of the brachial plexus. But still it is one of the few areas dreaded by the musculoskeletal disorders, and because of its complex anatomy and its bony relation, especially the clavicle hindering its exploration. So this is a picture to show the different roots, the trunks, divisions and cords and branches of brachial plexus. From the picture we can able to clearly see the roots, trunks and divisions are more above the level of clavicle. Supraclavicular brachial plexus block provide effective regional anesthesia to the upper extremity, but ultrasound examination of this region is still challenging with a few reference and anatomical landmarks. If you see the era of regional anesthesia, previously they used to do the brachial plexus block with reference to either interstitial groove or in relation to the pulsation of the subclavian artery. But over 2 decades, they can able to clearly visualize the brachial elements, but they used to say as vaguely terms like bunch of grapes or cluster. It was even recorded a study by Carlo D et al. So here comes the importance of our study. We wanted to do the present study to correlate the sonoanatomy with the actual anatomy. Even though it is not done with the CT or MRI images, it is better done with the ultrasonography. And also there is a lack of knowledge of exact site of injection, whether we are injecting into the root or trunks or divisions or the cords. So we took the study to identify the part of the brachial plexus above the clavicle and to correlate the evidence of the actual anatomy with the sonoanatomy of brachial plexus above the level of clavicle and to interpret the ultrasound images obtained at the level. So we have done the study in the Department of Anatomy and Anesthesiology, MGMCRA. It is an observational study. We have used the voluntary donated bodies from our body donation program called MOSHA. We choose 5 embalmed cadavers, 3 male and 2 female. And we excluded the cadaver with gross neck deformity and delayed embalming cases. And first we started doing sectioning of the cadaver and scanned with ultrasound, and thereby we been able to identify the brachial plexus elements. So after identifying the brachial plexus elements, we want to see where exactly we are injecting. So we tagged with the needle as shown in the ultrasonography, and we marked the skin at the particular plane and we sliced at the marked area. So like that we have done a different sequential oblique cut sections, and each section we have done a final dissection to track into the actual anatomy area as compared with the sonoanatomy. So what we observe at each level, we can try to correlate the cadaver image with the sonoanatomy image. So at the level of C5, we can able to identify the C5 root in relation to, first we see the picture, we can identify the carotid, internal jugular vein, the sternocleidomastoid muscle, anterior scalene and middle scalene. So in relation between the two scalene muscles, we can able to identify the vertebral artery. Just above the level of the vertebral artery, we can able to identify the C5 root. And this C5 root also lies in relation to above the level of the two tubercles of the transverse process of the C5 vertebra. So we can able to see the bifid transverse process of the C5 vertebra. So this we correlated with the same ultrasound image of time. So here we can able to identify a single round hypoechoic shadow appearing on the top of this M-shaped hyperechoic white line. So the root will appear like a hypoechoic shadow, the C5 if you see in the picture, whereas the bony point will appear like a hyperechoic white line. With this black one we can see is a post-acoustic shadow. So this is a picture to correlate with the C5 level. At C6 root, we can able to same like a C5, where we can able to identify the C5 is here, the marked one, and then we can able to identify the C6. This also lies in relation above the level of the vertebral artery on just above the top of the two transverse tubercles of the C6 vertebra. It's like a M-shaped structure. So same thing when we see in ultrasonography, we can able to see the C5 root here because we are going at the level of C6. So C6 also we can able to see as a hypoechoic shadow on top of this M-shaped hyperechoic white line, which is anterior and posterior tubercle of the transverse process of the C6 vertebra. So thereby we can even able to correlate the C5 and same like C5, we can able to correlate the C6 root. So at the level of C7 what happens? Because from C5 and C6 more or less the ultrasonographers have the same finding. But when we compare with the C7, here also we can able to make the C5 root, C6 and C7. Here the C7 is lying over the long transverse process of the C7 vertebra. Here because C7 doesn't have anterior tubercle, it has only the posterior tubercle which has been marked as a PT. So same like when we do in a scan, we can able to identify C5, C6, C7 as hypoechoic shadow, whereas the long transverse process with posterior tubercle of C7 appear like a hyperechoic white line. So that indicates, so we can able to clearly visualize the C7 over the long transverse process of the C7 vertebra. So this is the image of C7. At the level of C8 root, here also we can able to see, but at this level we can able to make C5 and C6 join together to form the upper trunk, and C7 remains as middle trunk. C8 we can able to see above this bony prominence, which is the first root. This line, the dotted one is the first root. Because ultrasonographic thought previously it was the transverse process of T1 vertebra where we are seeing the C8 above it. But when we do anatomical correlation only, we can able to find it is not the T1 transverse process, it is the first root. Because T1 transverse process lies still deep to it. So same thing we correlated with the ultrasound. We can able to see the upper trunk. Previously it was like this. We can able to see upper trunk by the joining of C5 and C6, middle trunk, C8, and this hyperechoic white line is the first root. Then last root is a T1. So T1 also we can able to make. Here is the area where upper trunk started forming anterior division and posterior division, which is very well seen in the picture, and middle trunk remains without producing any divisions, and we can able to make the C8 root and T1 root. Here in this picture, T1 lies below the level of, if you see here, T1 lies above the level of the rib and below the level of this pleura here. So just above the pleura, T1 is there. So from the ultrasonography view also, we can able to clinically correlate. First is the upper trunk anterior division and posterior division in the picture I am showing again, and the middle trunk. C8 we can able to make, T1 we can able to make here, but in between the C8 and T1 we can able to make this hyperechoic white line, which is the first root, and still below the T1 what we can able to make is again a hyperechoic white line, which is the pleura. So this is a very important findings for the ultrasonographer to block the T1 root that lies between the first root and the pleura. So this is a correlation. So what I said, the bunch of grapes, by putting everything together, then we identified bunch of grapes is nothing but is the upper trunk anterior division and upper trunk posterior division, middle trunk and inferior trunk, everything grouped together behind the subclavian artery above the level of the first root. So this only they used to say as the term bunch of grapes or the clusters. So this correlation was previously studied, but not as this is a trunk or root. They found that it is around hypoechoic nodules on transverse sonogram. But in the present study, we identified in relation to the vertebra. Either it is a C5 between the two tubercles or within the transverse process. A study by Lepek in 2014, he identified the roots in relation to the shape of the transverse process. In the present study, we found C5 and C6 root lie above the bifid transverse process. C7 root appears over the flattened transverse process of the C7. So again another thing, they said as clusters. We identified everything is a different neural elements present above the level of the clavicles. So to conclude, this sonoanatomy of the brachial plexus requires a good grounding in anatomy. So because it's a very importantly used technique with higher definition and dynamic character, and it is perfectly feasible with rapid practical and theoretical training. So we undertook this cadaver study to confirm and validate the sonoanatomy of the brachial plexus to produce the corroborative evidence. So these are my references. Thank you.
The table is open for discussion.
Yes. Actually, ma'am, we tried getting the specimen initially. Then because of the difficulty in transport and all, portable ultrasound machine was there in our college. So it was transported to the anatomy dissection hall, and there we have done the scanning of the cadaver, ma'am. For research purpose, we got permission, ma'am. From our own college, Dean and Vice Chancellor. Department Anesthesia HOD, because the part of the study is Department of Anesthesia HOD and professors. No, ma'am, the probe they were used to pack with cello tape, with perfect precautions only we have done, ma'am. And we even bought one new probe also, ma'am, for this. We just completely packed with the cello tape, ma'am. And then we have used the gel. Initially, we had difficulty in getting even the ultrasound images, ma'am. So first, without cutting the cadaver, we tried with the whole embalmed body. Even before embalmed body also, initially as we got it, we tried it. But sometimes transport of delayed embalmed cases, we thought many air bubbles was there. We are not able to get the picture clearly. Then we have just done a section. We immersed in water for a long time. We hope that air bubbles we may dissolve. Then after 1 week, we have started doing this same type of scanning. In some of the cadavers, out of 5, in 3 cases, we can able to get all these images. 5, ma'am. 5 we have used. 5. 5 on both the sides. Neck region, ma'am. 10. 10 side of the neck of 5 cadavers. Main thing is it is not a documentary evidence for any treatment. It is just for where they are seeing. Previously, they used to think that in relation to some bony point, they are seeing C7 root or C6. So they wanted to confirm their ultrasound image with the anatomy. So actually, they first come forward for a regional anesthesia course. They wanted to study. Then we had an idea, why can't we correlate with the anatomy image for help them? Even they identify some signs from it. They used to explain C5 root on top of a mountain, 2 mountain as a M shape. So that is very useful for their findings to see the images in the patients. Yes, ma'am. Now, because of that, they can able to even singly identify this is C5, this is C7. Even one root can also be blocked separately with the anatomical findings. Yes, ma'am. Yes, ma'am. Blindly they are doing for supraclavicular region previously. Now with By seeing the ultrasound, now they are doing even many of the volunteers workshop also they are happening. So they are doing more workshops, ma'am.
Any questions from audience, please?
Any questions from the audience side? By Dr. Sendalkumar, faculty, 9 commissions regarding the barrier medical college, Salem, on title, Ocular Impact on Chronic Smartphone Users.
A very good afternoon to senior anatomists and my dear friends and colleagues. Today we are going to see an important topic, that is going to be the ocular impact of the smartphone users. So just to have a brief introduction, various international reports was reported that the most common problem on smartphone users is diplopia and dry eye. Studies on smartphone usage in young adults reports that around 12 to 18 years old, with a minimum duration of 4 to 6 hours per day, they spend on the phone. The association between the smartphone use and the prevalence of ocular manifestations has recommended the need of health education programs on smartphone use and as well as its ocular impact. Increased use of smartphone devices even produced acute acquired comitant esotropia in adults. So, aim of the study to evaluate the influences of smartphone use on ocular symptoms, the status of the tear film stability and the volume assessment. Objective to investigate the influence of smartphone reading on the ocular surface, to correlate the smartphone vision syndrome on prolonged use of smartphones. So with this aim and objective, move on to the methodology. The study design is a cross-sectional study with a study population of 100 volunteers, grouped into 2 groups, control group 50 and smartphone users 50. A structured validated questionnaire was used to collect the details of the smartphone usage, and various parameters such as visual acuity, that includes the electronic version of Snell's chart, intraocular pressure, which was done using the non-contact tonometer, followed by the tear film stability study by fluorescence, but that is tear breakup time test, which is done by fluorescent dye installation, and then it is assessed with the cobalt blue light and the time is counted in seconds. Tear volume assessment was done by Schimmer's test, where a small strip of paper was inserted and the strip was removed after 5 minutes and the amount of tear produced in that time is measured and that is interpreted. The test was done on both right and left eye and was analyzed to check out the ocular defects in chronic usage of smartphones, as well as the smartphone vision syndrome score was analyzed and the ocular manifestations are noted and correlated with the duration of usage. Smartphone vision syndrome, this is a scoring method where we have standardized the score method. Actually they have done it for computer vision syndrome. It was modified and later we have piloted it and then we have structured it. So these are the 5 basic questions which deals with the smartphone vision syndrome. Basically how they feel when they use the smartphones, and burning sensation, tears, eye feeling dry, and these are blurred visions. All these are the basic questions, and based on this the scoring will be given. Moving on to the result, the basic questions we have just added up to just avoid the confounding factors. What just made them to buy phones? Amazingly, they just told it is education. Smartphone usage purpose, they told just all the above: education, chatting as well as movies. And the duration and the time period using the smartphone, most of them use frequently, that is around 1 to 2 hours per day. Average screen time per day was found to be around 5 to 8 hours in 40% of the study population. And how much time they spend in the night time for the smartphones? Yes, they do agree that they spend a lot of night times in the smartphone. Will there be an interval between your eyes and the phone screen? Yes, they told they have an interval, but as they keep on using it, the interval or the frequency keeps lesser. So do you see the smartphones through spectacles or contact lens? Agreed. So around 53% of the population told that they are using the spectacles and the contact lenses. And have you ever done the eye checkup? Yes, most of them told, 87% told that they have undergone the eye checkup. And the screen brightness of their mobile while using it, most of them use the medium screen brightness when they use the smartphones. So these are the basic questionnaires, and we have added just a basic thing to find out whether their addiction also. Have you ever regret of over usage of mobile phones? Yes. And will you check your mobile phone soon after your wake up? Yes, very often. And whether your mobile phones having game app? Yes, they agreed that they have a lot of game apps also in that. So we have also asked about the ocular thing. We have just asked them whether they use artificial tears. Around 93% of the study population, they told they are not using it. And the various effects what they have come across while using the smartphones includes eye strain, which is found to be very frequently occurring, redness, itching, headache, lacrimation, dryness of the eye followed by the visual disturbances. And most of the symptoms were found frequently in the smartphone users. Moving on to the interpretation of the parameters, when we compare to the age and the sex, we have recruited two groups, control group 50 and the smartphone user groups 50. And the table shows the percentage of the people, male and female sex and the age groups. And the use of glasses is also noted. 34% of the people use glasses in the control group, whereas it is more, 53% of the people uses spectacles or the goggles in the smartphone users. Coming on to the intraocular pressure, which is done by non-contact tonometer. So when it is compared to the control, we have taken only the baseline data from the control because they are using not the smartphone, they are using the regular phones. So we have just taken the baseline data, but we have taken three datas, baseline, 1 hour and after 4 hours of usage. And when we screen this baseline data, amazingly we have found that when it is around 4 hours, their intraocular pressure seems to be increased, which is of around 23.41 on the right side and 23.32 on the left side. So the tear film stability test and tear volume assessment both were done by fluorescence butt and the Schimmer's test. And the baseline data was taken from the control group as well as the smartphone users. So the baseline data, which is compared to 1 hour usage of the smartphone and 4 hours usage of the smartphone, showed that when they use for 4 hours, their fluorescence dye which is installed into their eyes showed differences more, and the Schimmer's test also their eye seems to be very dry, which is around 7.26 in the Schimmer's test. Smartphone vision syndrome, we have taken the following scores including fatigue, burning, dryness, blurred vision and dullness. When it is a chronic use around 4 hours, yes, all these were found to be increased when they are using continuously for 4 hours. So various studies were just compared, but actually they haven't done a specific studies which pertaining to my topic of research, but I have taken few studies which is done already. Based on the dry eye disease, which is of around 6.6% reported by in study done in the Korea, and whereas ocular surface disease index, FBAT and the skimmer score were found to be increased in the smartphone users, which was reported by Hang Chow, which was done in 80 volunteers. Whereas in India, in case of India, the score of OSDI, VAS visual analog scale, fatigue, burning sensation and dryness showed significant increase after the usage of 1 hour and 4 hours. The same in Saudi Arabia, 760 volunteers were involved and they reported that 36% have ocular symptoms directly after using the smartphone, and 50% has undergone for myopia, and around 39.7 will have the ocular pain or the dryness after the prolonged use. Whereas the study done by Acharya et al. In 441 study population, all the symptoms of smartphone users that includes headache, lack of concentration, irritability, anxiety, lack of sleep, exhaustion, eye strain and fatigue were all reported. So just to come to the conclusion, smartphone use can deteriorate the tear film via the reduced rate of blinking, incomplete closure of the eye and exposure of the ocular surface. It can also induce the oxidative stress response at the ocular surfaces, thus aggravating the ocular symptoms. And also the smartphone vision syndrome and dry eye disease must be detected earlier and should be treated with appropriate medical as well as environmental interventions and educating them. So the management of ocular problems associated with excessive smartphone use should be recommended, and we have to prevent the youngsters from overusing the smartphones. So these are my references. Thank you.
complications of smartphone are well known, whatever you have discussed, but what is the solution?
Ma'am, actually I included in the last part of the slide. So whether we can go for the goggles which is readily available in the market.
Okay.
And we have the clear film thing also which is on a mobile phone screen itself we can attach it and then we can refrain ourselves from this too much of stressing our ocular nerves. And also we have various yoga for the exercises. That will be the second part of my study. So I am planning to apply these sort of exercises and see whether it really works out and whether the visually acuity and all the other things gets changed including the intraocular pressure. But still our phone, every one of us have a smartphone, but the smartphone clearly gives us screen saving time. But we never bother about it, and most of us are not aware also. So this is an automated setup in all the smartphones. So whenever we want to when we exceed the time of usage, automatically the screen dullness or the brightness gets fade off. So we have all these apps already available. Since it's a very deleterious effect, we have to focus on this and we have to tell the youngsters that they should prevent their eyes. And because of COVID, I myself I'm setting an example. So because of COVID, too much of mobile phone usage, I started wearing my goggles.
See, out of so many parameters which you have included, anything different or new parameters have you included in this?
Actually, this Shima's test and stress chart and the tonometer, intraocular pressure is no far reported. When the studies are done, intraocular pressure is increased due to overusage of smartphone. That is the novelty of my study. So no far they have reported. Only very few studies they have done mainly for the dry eye disease. That's all. They haven't reported even that intraocular pressure rises. So the main problem will be if this intraocular pressure keeps on rising, so automatically they will go for glaucoma. So that is very serious. So we have to have a limitation somewhere or the other, otherwise it will be ending up in big.
Sir, this study is very appropriate, especially because all of us are very sure are smartphone users. I have only one doubt, whether the time used in the phone, whether recall by the for whether cross-check using the
No. Actually the volunteers whom we have recruited, they use the phone. So we have the option in the screen timing we can see, we can check in our phones. So we get the screen timing and check there. So based on that we have just categorized it, 1 hour, 3 hours, 2 hours.
because recall they may not be very truthful.
Every one of our phone clearly gives the screen usage time. So it shows automatically we can get them.
Thank you.
Thank you.
Thank you. With this presentation, we are finishing the presentations under faculty category. Let's start the presentation under UG category for Dr. Leela Krishnamurthy Award. On title, a study to access the cytogenetic toxicity and the expression pattern of N-cadherin in buccal epithelial cells of COVID-19 patients.
Good afternoon to all. I am going to present my research paper on the topic, a study to assess the cytogenetic toxicity and the expression pattern of N-cadherin in buccal epithelial cells of COVID-19 patients, undertaken by myself, Vishnu B., final year MBBS student in All India Institute of Medical Science, Mangalagiri. The pandemic COVID-19 caused by SARS-CoV-2 virus. The pandemic COVID-19 caused by the SARS-CoV-2 virus has infected around 7 million people worldwide and has caused significantly higher panic among the population. The virus mainly affects the oral and nasal cavity. Primarily by attaching its spike protein to the angiotensin converting enzyme 2 receptors present in the epithelial cells of respiratory and gastrointestinal system. Since, like other viral infections, SARS-CoV-2 also causes nuclear and genetic damage and cell death. Like in case of other xenobiotic exposures like alcohol consumption, smoking, and even infections, the amount of nuclear damage can be assessed by the presence of micronucleated cells and other metanuclear abnormalities. The complete pathogenesis of the viral infection and the effects of the viral infection on the genetic and nuclear material is not exposed. So the study was done to evaluate the micronuclei count, metanuclear abnormalities, and genotoxic factor in the buccal epithelial cells of COVID-19 suspected patients. Since the viral infection causes nuclear damage, it can alter the properties of epithelial cells, potentially leading to cancer cell characteristics. N-cadherin or neural cadherin is a calcium-dependent adhesive molecule present in the mesenchymal epithelial cells. Usually, these are not expressed by the epithelial cells. The presence of N-cadherin can be assessed to assess the tumorigenic potential of the SARS-CoV-19 infection. The objectives of my study was to estimate the buccal micronucleated cell count and metanuclear abnormalities in symptomatic COVID-19 suspected patients, to calculate the genotoxic factor, and to study and compare the expression pattern of N-cadherin in COVID-19 suspected patients. This cross-sectional study was conducted among symptomatic COVID-19 suspected patients visiting the outpatient screening area for RT-PCR COVID-2 between the months of August to October 2022. The sample size was 100. The sample size was divided into two groups. Group 1 containing 25 RT-PCR positive patients and Group 2 containing 75 RT-PCR negative patients. After obtaining the consent from the patients, the buccal smear was taken using a wooden spatula. The buccal smear was then smeared to a pre-labeled glass slide. Then it was sent for rapid pap smear. Then it was evaluated for micronucleated count and other metanuclear changes count. Then the genotoxic factor was calculated. Also, the buccal smear was sent for immunohistochemical stain for N-cadherin. Then the results of all these three was compared between RT-PCR positive and negative samples for any significant findings. These were the results of my study. The first figure shows the presence of micronucleus in a cell. So this is a micronucleated cell. The micronucleus is an extranuclear material which has the same intensity of staining as that of the nucleus. The other three pictures shows the metanuclear abnormalities. The first one is the pycnotic nucleus. Pycnotic nucleus refers to the small condensed nucleus due to nuclear damage. The second figure indicates cheirorexic nucleus. Cheirorexic refers to the process of fragmentation of the nucleus. The last one is the cheirolytic nucleus. Cheirolysis refers to the dissolution of the nucleus. As you can see, this is the micronucleated cell count for COVID positive patients, and this is the micronucleated cell count for COVID negative patients. This is the total micronuclear count in positive patients and total micronuclear count in negative patients. As you can see, the value is significantly higher in case of positive patients. As it is mentioned in the graph, the blue one stands for COVID positive patients and the orange for negative one. The value was around 3 times higher in positive patients compared to that of the negative patients. This is the pycnotic cell count in positive patients. This is the cheirolytic cell count, and this is the cheirorexic cell count, and this is the cheirolytic cell count in positive patients. As you can see, all the metanuclear abnormalities are also significantly elevated in positive patients than compared to the negative patients. The genotoxic factor is calculated by the ratio of frequency of micronucleated cells in COVID-19 positive samples to that of the negative samples. The frequency of micronucleated cells in COVID-19 positive samples was found to be 15.24 in this study, and the negative sample it was 5.69, and the genotoxic factor turned out to be 2.68, which will be falling under the slightly positive criteria. Any genotoxic factor value beyond 1.4 will be taken as positive. So, the SARS-CoV-2 infection is having positive genotoxic effect in the buccal epithelial cells. This is the result for immunohistochemical staining for N-cadherin. The first figure shows the intensity of exposure of N-cadherin in the surface of epithelial cells in COVID-19 negative patients, followed by the two figures which shows the immunohistochemical staining results for positive samples. As you can see, there is increase in intensity of the stain around the periphery of the epithelial cells, more in the positive samples compared to that of the mild staining in the negative sample. Due to the higher turnover rate in the mucosal epithelial cells. These cells are continuously renewed by the process of mitosis. Any factors such as infection and inflammation can affect the mitotic figures, leading to malsegregation due to improper attachments of the spindle fibers, leading to the formation of micronuclei and other metanuclear abnormalities. This occurs mainly due to excess activation and elevated immune response by the virus through the interleukin 1, beta and TNF alpha secretions. So then there are studies which shows that there is increasing relationship between nuclear abnormalities and increased incidence of cancers. Also, the increased expression of end gathering suggests that the epithelial cells has lost their polarity and they are becoming more of an invasive mesenchymal type of cells. This is the possible mechanism for the cytotoxicity due to the SARS-CoV-2 infection. The SARS-CoV-2, as I said before, attaches to the ACE2 receptors and it increases the release of interleukin 1 beta and TNF alpha. It causes abnormal ATM kinase activation, leading to DNA damage by the separation and breakage of the DNA strands. It all results in the formation of micronuclei as well as other metanuclear abnormalities. Thus, it will trigger the formation of epithelial to mesenchymal transition. The study concludes that SARS-CoV-2 has positive genotoxic effect and expresses its carcinogenic toxicity by increasing the micronuclei, chirolysis and bichloric cell count. There is the increased expression of end gathering suggests that there is increased epithelial to mesenchymal transition, thus suggesting that the infection has positive tumorigenic potential. In summary, SARS-CoV-2 infection is having positive cytogenotoxic effect. These micronucleated cell count, metanuclear abnormalities and end gathering expressions can be used as a reliable marker to assess the early genomic damage caused due to the infection. These parameters can also be used as a method to prevent and diagnose early precancerous lesions caused due to the viral infection. These are my references. Thank you for the opportunity. Thank you.
The paper.
Ma'am, actually this is an ICMR SCS project. So I did this study with the help of my guide.
This was concerning which department and all, because it belongs to cytogenetics.
Yes, ma'am.
So during the study, which year you were?
Ma'am, I was in second year.
Second year, okay. So cytogenetics comes under which department?
Ma'am, the buccal samples, buccal smears as well as the staining was done under histology and it was under anatomy department. Yes, ma'am. It is an ICMR SCS approved project.
What is the duration of your project?
In August to October, 3 months.
3 months.
Yes, ma'am. Yes, ma'am. My guide is there, ma'am. Dr. Shankaran sir, additional professor of anatomy. Thank you.
Next presenter is Dr. Danush Aditya, student, ESIC Medical College and Hospital, Chennai, on title, How Common is Appendages of Testis and Epididymis and Their Positions, a cadaveric study in South Indian population.
A very good evening to one and all present here. Myself, Danush Aditya from ESIC KK Nagaram Hospital. First, it's an honor to stand here and give this conference. Okay, let's start. Now, let's start about the introduction topic. This is about the gross feature. Okay, first, what do you know about testis? Testis, we all know that they are actually extra abdominal structures present within the scrotum, and it's actually 25 grams in weight, 4 to 5 centimeters in length, and 2 to 3 centimeters in diameter. And it's actually covered by a fibrous capsule called tunica albuginea. Okay, and testis also has 200 to 400 wedge-shaped structures, which are highly coiled. They are each 200 to 300 wedge-shaped lobes, which contain 3 to 10 highly coiled structures called seminiferous tubules, which actually make up the spermatozoa. Okay, First, during dissection, how do we access the testis first? First, we need to separate the skin. Below the skin, what do we have? We have the dartos fascia, and below that, what do we have? We have the external spermatic fascia, and below that, we have the cremasteric fascia, and beneath that, we have the internal spermatic fascia. And after that, finally, we reach the testis. Okay. Now, let's move on. Just a minute. Okay. Now, I'll just talk about the embryological aspect of testis. We see here two diagrams. First is male and female. This is actually the development of testis. I would like you to remember just three numbers: 3, 4, and 6. What are these numbers? There are weeks of developments of embryo. During the third week of development, actually the epiplastic cells will actually proliferate, and the cells would actually move towards the border of the yolk sac near the allantois. That's the third week. And during the fourth week, what would happen? They become amoeboid in shape, and they actually move along the dorsal mesentery of the hindgut. And during sixth week, what happens? They actually penetrate the genital ridges. What are the genital ridges? They are actually present in the dorsal. They are actually present in the dorsal aspect, lateral to the hindgut. So these are called genital ridges. Okay, let's move on. Okay, our study. The aim of our study is to identify the testicular and epididymal appendages, to know the incidence in South Indian population, to study the morphology, morphometry, and in depth the shape of the appendages of testis and epididymis, to study the possible causes for various clinical conditions like testicular torsion, undescendant testis, torsion of appendix of testis and epididymis, cystic swelling of testicular appendages, epididymal appendage, and acute scrotum. Materials. The materials which are used here are 10 testes from adult embalmed cadavers, vernier caliper, digital, that's DSLR camera, and Macintosh. So the observation, actually we took 10 samples. Out of the 10 samples, 7 had appendages, and out of that 7, 4 were from right testis and 3 were from left testis. Okay. Now let's move on. This is actually the table which I have made. This is the morphometry of appendages of testis and epididymis. The measurements are actually taken from the head of the epididymis, distance from the head of the epididymis, appendix of testis. Okay, first we see the left testis. LT1 means, which denotes left testis 1 is 6 mm, LT2, second testis 9 mm, and third is 10 mm. Okay, that is actually the picture of one of the sample which is taken during our study, and the table 1.2 depicts the right testis, the measurements of the right testis. This 12 mm, 10 mm, 9 mm, and 16 mm. And we also see the morphology of appendages of testis and epididymis. Here I want to say the appendix of epididymis are a rarer sight when compared to the appendix of testis. So they were actually present in the right testis. Only I said that we took 4 right testes. Out of the 4 right testes, only 2 right testes had these. That's like 2 mm and 3 mm. Then we move on to the morphology of appendages of testis and epididymis. Like AT depicts appendix of testis, AE depicts appendix of epididymis. The right testis is membranous, and in first testis it's membranous, second is pedunculated, third is membranous, and in fourth testis it's round. And appendix of epididymis, in first 2 testis it's present, and in the third and fourth testis they are absent. So it's membranous and pedunculated. Then we move on to the morphology for the left testis, AT. That's like for first testis it's pedunculated, membranous, and in second for appendix of epididymis it's absent in the left testis completely. This is actually the image of one of our samples which we have taken. Then we move on to the length of appendages of testis and epididymis. We actually measure it using a meter scale. Let's move. That's right testis. That's like 3 mm. First testis is 3 mm, second is 3 mm, third is 1 mm, and fourth is 4 mm. And appendix of epididymis is 1 mm and 2.5 mm in first and second testis respectively, and in third and fourth testis the appendix of epididymis is absent. And this is the measurements of the left testis. Okay, let's go. Okay, the incidence of testicular and epididymal appendages in our present study. Out of the total sampling size, 70% had appendages, out of which 57.14% were from the right testis and 42.85% were from the left testis. Out of the 57.14%, 28.57% had epididymal appendages. Okay, let's move on to the discussion part. Imran Mushtaq et al. Published retrospective review of pediatric patients with acute scrotum on January 2003. where he conducted the study on 204 boys with 110 having torsion of testicular appendages and 40 having only testicular torsion, which shows 53.9% are presented with testicular appendage torsion and 19.6% having only testicular torsion. This shows that majority of pediatric age groups having acute scrotum present with testicular appendage torsion. Okay, what do we conclude using this study? The present study shows 70% of testis with appendages of testis in epididymis. So that this study is actually on par with the study which we have conducted showing greater incidence of torsion of testicular appendages compared to the torsion of testis. Let's move, okay. Let's move on to the second discussion. In a study conducted by Balakrishna et al., tossed appendix of testis, retrospective analysis of clinical profiles of 13 surgically diagnosed cases, he actually depicted the normal average length of appendix of testis is like 1 to 7 mm in length and it's oval and pedunculated. And the testicular appendage is most common cause of acute painful hemiscrotum in a child. So our study is actually on par with this study. So we showed that the average length of appendix of testis in epididymis is like 1 to 5 mm, which is almost on par with the study conducted by Mr. Balakrishna. And yeah, let's move on. In this study, almost 30% had no appendages. The epididymal appendages were a rare sight compared to the incidence of testicular appendages. Okay, let's conclude. This study helps us to understand the incidence of testicular appendages in South Indian population and is helpful for general surgeons, pediatric surgeons, general physicians to know the real cause for various clinical conditions like testicular torsion, undescendant testis, torsion of appendix of testis in epididymis, cystic swelling of testicular appendages and epididymal appendage and acute scrotum. Okay, this is actually the reference which I have taken. Thank you so much.
See, which year you belong to?
First year, ma'am.
First year, okay. So this, you have not shown the photos of the specimen of left testis.
Actually, I'm having all these photos, ma'am, but in this study, like I included only some of them. I'm having.
So these measurements and all, who has taken? Measurements and all, no, of the specimens, who has taken?
I have taken it.
So how do you determine the side of a testis?
Like using that
side of the testis.
Yeah, using the sinuses, ma'am. The sinuses should actually face like laterally, so that we can decide whether it's right or left. The sinus means there's a space between the epididymis and the testis. So based on that, we will determine the side of the testis.
Yeah. So where it should face?
It should face like laterally and.
It's a good presentation, I'd say, but whenever you are using any photograph or something, use pointer. Okay, I have seen nobody has used pointer here. You are showing with your finger. So in future, use your pointer. Okay? Any question from audience, please?
While cadaveric study it is difficult to conduct, I understand that, but 10 is a very small size. At least the old samples would have been used when we are, especially when you are comparing with the one was 700 odd. The other one was 13, that is okay. But when we are making a comparison, 10 is not statistically significant. Minimal number is 30 for a statistically significant study. At least the old samples can be used, or I think you can at least consider doing it in more specimens. And also it is better when it is a paired organ, it is better to have equal number of right and left, so that the conclusion which is drawn is more appropriate.
Okay, thanks. Thank you, judges.
To the end of this session, let's sit and relax for a few minutes for the judges to announce the award winners in each category. Welcome our judges to the stage.
Good evening all. Let me announce the Good evening all. Let me announce the prize winner under Dr. M. Cooper Award, faculty category. It goes to Dr. Prabhavati Gajendran for the topic corroborative evidence of gross anatomy and sonoanatomy of supraclavicular brachial plexus, a cadaveric study. And the prize winner under Dr. Leela Krishnamurthy Award for undergraduate category goes to Mr. Vishnu B. For the topic as study to assess the cytogenetic toxicity and the expression pattern of N-cadherin in buccal epithelial cells of COVID-19 patients.
I also request the judges to present the participation certificate to the other presenters. Dr. Suganitha Balasundaram, Dr. Senthil Kumar, Dr. Danish Aditya. Judges, please stay on the stage. Now I request Dr. Sumati, Professor and HOD, Balaji Dental College, to present a small memento to our judge, Dr. Melanie Rajendran. I request Dr. Virendra Kumar Nim, Professor from PIMS, to present a small memento to Dr. Sudha Rao. Also, I request Dr. Prakash, Treasurer, Association of Anatomists-Tamilnadu, to present a small memento to Dr. Vijisha Palguni. And it's time for a small break for 5 minutes, followed by the general body meeting. All the members of the association can join with that. For others, we are partying here today. We'll meet tomorrow again. Till then, with lots of thanks, organizing committee EEE-2023. Thank you.